none other than my Paul. He takes the lead and he'll set the ball rolling.
Thanks, Sanjay. I'll be talking about a brief insight into the upcoming platforms of refractive lenticle extraction. As you all know that refractive lenticle extraction is the way things are going. Anywhere in the body, wherever the incision is smaller, that's been lapped up and that's been accepted all over. And there are several studies to show that the outcome of the small incision lenticle extraction by far, as regards the biomechanical stability, outcomes, retreatment rates, and dry eye far supersedes any laser vision correction procedure. Now, SMILE, which came in more than a decade ago, and we are proud that the first SMILE procedure was done by Centrosite in the world when it was being developed. And as you all know that in the SMILE procedure, there are four parts to the, one is the table, or including the table, the posterior of the lenticle, then you have the side cut, and then you have the anterior, there, which is the cap cut, and then you have a 2 millimeter or a 3 millimeter incision through which the lenticle can be removed. Now, these are basically the machines which are available or going to be available, and this is just a comparison. As you all know, this is far infrared. 1043 is 1030, 1040, 1043. That's the wavelength which you have. The pulse repetition rate has gone up from 500 to 2 megahertz. In Zemer, it's 20 megahertz, and Schwind has also come out, which is 4 megahertz, and Elita is 10 megahertz. So the Elita is by Johnson Johnson, and Alcon has also started clinical trials on their lenticle extraction, and again it's great that the trials are also happening in India. This is the energy that is being used. So as you can see over time that the energy that is being used has significantly reduced, and you can see that we are down to about 50 to 70 nanojoules, which is the least energy that is being used in the Johnson Johnson system. The treatment time from about 25-30 seconds has come down to about 10 seconds in the Visumax 800, and it's about 16 seconds in the Alita J&J system which is there. Patient interface, you can see, could be curved or could be flat. Cyclotorsion compensation is coming in except for the Visumax 500. All are having cyclotorsion compensation, and also the centration system is there. This is the Z8, which is by the Zemer, and here normally there are two incision cuts which are being made, one to merge with the anterior of the lenticle and the other to merge with the posterior of the lenticle. The compensation of cyclotorsion is there. This is thanks courtesy Kumar doctor, and after the laser has been done, you can see this is going into the anterior. Very easy dissection. This is the posterior, as you can see, and these are the two cuts, and then you can see that the separation is pretty easy, and you can remove the lenticle. As you can see here, the lenticle can be easily removed with little or no adhesions which are there. This is the Visumax 800. As you can see, the Visumax 800 is a pretty sleek looking machine. That's the arm which comes on, and then as you can see, with the use of the IOL master, it couples with the IOL master 700, and you can see that there's a cyclotorsion compensation as also a central alignment system which is there. So couple of issues that were being raised about the lenticle extraction as regards for the correction of astigmatism. The cyclotorsion compensation has come, and the central alignment is there. This is the silk, which is the small incision lenticle keratomelusis. This is the Elita system. Again, we were the first site globally to start the work on this, as the FDA 1, 2, and 3 now, and now there is going to be a limited market release which should start in about 4 to 6 weeks globally, which will be about 20 units which will be available. CE mark is available. It's been approved in India. FDA, I think, will come pretty soon, and this is how the footprint of the Elita looks like. Well, this is the docking, as you can see. Those who have used the intralays, it is pretty similar to that, and you can see the centration. We have a mark on the centration, and this would be the treatment which will be there. So you can see that this is how the machine is working. You can see that is the cone being read just now on the right side, and that means that is the calibration of the cone, and one would be a flap and one would be a lenticule extraction, as you would see in these two cases. So this is the applanation in this case. This is the docking on this side that has been completed. You go into the yellow zone to press on this. You pinch the valve. You can see this is the applanation that is happening, and the person. Uh, the good thing about this is that the suction is pretty hard. So you can call it as a good or a bad thing, but this we have not had in more than 300 eyes even a single case of suction loss in these cases. So you can see that's the centration, that is the uh, entry cut. This is again, you can see this slight off center, so we are centering it. This is similar to the GUI that you have on the interlace which is there. This throws up, if there is a floating head, the machine will stop. If there is a excess scleral show, again the machine will show. And you can see this is the 16-second that the lenticule, this is the posterior lenticule, this is the side cut, and this is the cap which is being made, and then you will have the incision. This in this side you are having the flap that is being done, and that is the pretty much the end of the procedure that you have. So this is the lenticule as to how it looks. And now you can see that the lenticule removal, this is OCT guided. You can see this is clear cut, the lenticule that you have. The entry is fantastic. You really don't have any issues in the entry anywhere. This is actually a manual cyclotorsion compensation, so you can see these marks, and this is the centration mark, and you can see going anterior, posterior onto the lenticule. Again, you can see the lenticule being shown pretty much in the OCT. This is the separation. You can see a piece of cake, really very good, and centoposite was the first study started, and then it was NN, and now it is in Singapore, and this is the lenticule, and there hasn't been any instance of a retained lenticule in any of the eyes, and you can see we measured the lenticule, the size is exactly the same, and this is on the OCT that you measured this. I'll just say that we have done a nomogram adjustment. The first cohort had 118 myopic eyes, the second had 106 myopic eyes, and there has been, if you could see that there was a slight undercorrection that we got in the first cohort, and as in the smile also, people tend to do a slight overcorrection. So similarly, there is a nomogram adjustment that has been done, and now the commercially limited market release sites are going to be nomogram 1 and 2 adjustments. So these are the adjustments, and you can see that the tightness of the results are pretty good. Standard deviation of the correction was only 0.14 diopters at 3 months, as to an evidence for very low variability that is there. No patient has had to get a retreatment done in any of these cases. So after implementing the nomogram, 90% of the eyes at 1 month post-op were within half a diopter of the intended, and this is much better than any laser vision correction reports that are available. Uncorrected visual acuity, you can see 2016 or better in the second cohort is what we are looking at, and now we are having a slight adjustment in the astigmatism, so it's the third cohort that we'll come out with, and you can see that more than 40% of the patients have 2016 or better. Uncorrected visual acuity, this is again after nomogram adjustment, you can see 2016 or better. Pretty good, and there was minor or no tissue adhesions that were there. Corneal biomicroscopy was unremarkable, and the study demonstrated actual excellent visual outcomes in this. So I have also personally played with the Schwind at the ESCRS, and that they don't do below -2 as things stand, and that also is giving a fantastic outcome, and let's see what the Alcon machine comes out with. But the way refractive surgery is moving is towards a lenticule-based procedure because of the obvious advantage that you're making a 2 millimeter incision rather than a 22 millimeter. Dry eye is definitely, and biomechanical stability, etc. And if you have borderline corneas, the smile extra or the cross-linking, it has definitely been shown works, while the LASIK with an extra procedure does not work to that extent. So this is how things are, and the current platforms have upgraded, and the upcoming ones are on the horizon, and these updates have attracted more surgeons to shift to the lenticule-based procedure with comparable results to flap-based procedure, and lack of flap-related complication. Refractive lenticule extraction, I think, is the procedure that has come to stay, and if I have to put my money on anything, I think this is the procedure that's globally, if you think that's going to be the procedure of choice. Thank you very much for your kind attention.
A lovely presentation, Dr. Maipal. In fact, yeah. So I got an opportunity to try my hands in the ESCRS on the J&J machine, and the lenticule came out so smoothly. You just had to hold it and pull it out. So that was really fantastic. So Maipal has done a lot about it. Maipal, how would you compare your two experiences with the previous system and this J&J system?
So basically, as I told you, this is a hard dock. It's basically based on the intralace platform. So it's the same gripper that you have and put the suction goes pretty high. You do tend to get some cherry red spots. Lenticule extraction is pretty easy in these particular cases. It's basically, there's no spot separation. And it's a 1 micron spot, so it's just in that you have a spot separation. This is all total. So therefore, you can actually, there are minor adhesions that you have, like even the Zimmer has a very small site, so there also people who are working, there isn't hardly any separation that is required. And I told you that this is across 3-4 sites, that there has been no evidence of any retained lenticule or uncut lenticule. So that comes pretty well because there is no separation, no raster, no line separation, etc. And it's a pretty fast laser, that's 16, and I think what is in the works is a single PI, not a two-piece PI. This is a two-piece PI, and I think we should be starting those studies in May or June. That's for the flap also. But obviously they're pretty confident. That's why the limited market release is happening now. So there'll be 4 units in India by the end of this month.
So there's a lot of work going on this lenticle extraction platform. Almost, I think every company wants to come into this segment.
Yeah. So you might be knowing something better about Alcon, but my knowledge is that it's a UV light that they're trying to make into an infrared. So that studies have also started.
Thank you. Thank you so much.
Okay.
Sir, since a lot of players are there in market nowadays, so do you think that the price will also be competitively brought down sooner or later?
Still aware of the price that we are going to have from the J&J system because the limited market release is only for doing about 100 eyes. So after that, they will give us the price as to what they will sell the same unit to us. And what will be the market price, I think maybe in Cochin, I'll be able to tell you as to what the price is. Zimmer, if you have a fully loaded, I think that's about 4-5 crores. I've never negotiated, but I think that has the cataract also with the clear, that's what they call. Dr. Ramamurthy just got one. So I was speaking to him actually yesterday also. The only thing is you don't see what is happening below. So it's like an arm and that comes on the eye. It's a little big, but the separation according to him is also pretty good. Bharti has both the Smile and the Zimmer. So the advantage in Zimmer is that the PI cost is about half. मतलब वो 10,000 रुपए की है, I think मतलब they give for 20,000 for a pair, but their femto is higher. That's about it's the same 20,000 for one eye. So somewhere or the other for the femto I meant was femto cataract. So femto cataract is slightly higher. This is lower, the lenticule. So main thing is the price of the PI that's being charged. So I hope I've been impressing upon them that if you have to get a market share, make it cheaper, and like they did for the iHands, they did listen to us today. I think iHands is almost a gold standard. Like a lot of people have switched over from a normal monofocal lens to iHands. So if they give us a price of like their 8,000-9,000 for the intralace PI, if they give that, then it would be half of what the Smile people are charging. So I think that's the main thing. Let's see. Prices will come down obviously as things come upon, because everyone is moving towards that. There is another German company which I think Appa deals with. They also have a lenticule now. That's a German company. So lenticule is, yeah.
Zimmer offers one advantage is they say their machine is portable.
Ah,
you
that's
can
what
port
they
it
say.
between the rooms, and they say you can even port it between the centers. You can load it in a car or a van and take it to another center and do it.
Yeah, so
And it
actually
seems to be
we
working.
have done that for our Eximers long time with Sameer Shah and all, but that can be done. But ultimately it's an economic model that you have to work on. Hanji sir.
Sir, this instrument is separate the lenticule. It comes with machine or
नहीं that तो ये एप्सिलॉन कहीं से वो मशीन से आप मतलब
that is special
मिल जाते हैं आराम से, that's not a problem.
And sir, the lenticule,
Katina, Vatina, everyone. Sorry, lenticule?
we throw the lenticule, can we use in cases of corneal ulcer where one
Yes, you can. If you want lenticules, we'll be happy to give it to you. We use the lenticule for thin corneas, for cross-linkings. So instead of a contact lens, we are using, now there is the fluence, adaptive fluence that's come in with the Withdraw machine, etc., where you can give less amount for thin corneas. But way back about 7 years ago, we described the use of the lenticule to put it on uh, top of the thin cornea of a keratoconus and then do the UV radiation and throw it away. You can use it for melts, for puffs, etc. You can use it. Lenticules has been used for hyperopic correction for fili, and the lenticule has also been used for keratoconus, putting it and an implant which thickens the cornea in the center. So obviously it's corneal tissue which can be used.
Not only that, sir, from your institute, Amit Pandey presented paper yesterday that
on
he
the-
is using to cover the,
Yeah.
some of
Yeah,
the-
we sent him the lenticule from Baroda, but ठीक है, slipped out of my mind. But yes, that can be used for covering. Yes. Thank you.
Dr. Mahipal.
Thank you.
That was a wonderful info talk. So then I have the privilege now to invite Dr. Ameya Kulkarni, and he's talking on a subject which is my favorite. I love the way we put an ICL without the visco under hydro. And now we are totally onto that. It makes things a lot more easier and the results are really excellent. So let's hear Dr. Ameya, his
Yeah,
experiences.
I am greatly relieved. I have a supporter on stage. I've been trying to present this. I have been hammered in my home state for doing this. People are still not caught on to it. But let's, the basic thing here is it's very difficult to follow the big boss, but I'll try. Sir talked extensively on laser vision correction. Uh, what we've seen in the last 5 to 7 years is there has been an increasing demand of better clarity than what we offer for laser vision correction. There have been people with jobs like surgeons themselves who come to us saying they don't want to use glasses anymore. So what I'm trying to say is that the kind of patients we have for ICLs is now increasing. We are lowering down the threshold for which we can do ICLs. We used to do ICLs about 10, then we came to 8, now we also do ICLs at 6 diopters. I've had a patient who insisted only on an ICL at 2 diopters, so we've done that even. Now the basic roadblock for the ICL was the post-op headache for the patient and headache for the surgeon. Now why that happens in an ICL is because come what may, there was some amount of raised IOP in ICL. Basically the causes are the vault, which basically is sizing that's preoperative. You have retained viscoelastic at one end of the spectrum causing slight change in the IOP and the symptoms that occur afterwards, and the other end of the spectrum is always the Uretz-Zavalia syndrome, which has now come back and it's reported in ICL. The problem with retained viscoelastic is no matter how well we wash the visco, we cannot ever claim to have washed the entire visco while you're doing ICL or any phakic IL for that matter. It's the same as claiming you take out all the lens epithelial cells after cataract. It's not possible. It's the same way you cannot take out the entire viscoelastic. Some amount of viscoelastic remains there. So this is where we started doing under hydro about 5 years back, and it has been a great change in how we approach these patients, and we have been able to basically offer ICL surgeries for more and more people without the headache to them and to us even. So even while loading, the conventional wisdom has been that you need to put some amount of viscoelastic in the cartridge. Now my point is it basically changes the surface tension when you put viscoelastic over that BSS, and it basically will push your ICL upwards. So if you can load it without the visco or very, very minimal visco, that's the way to go. It will be loaded faster. It doesn't jump back while you're trying to do things. Once you've loaded it, the point here is to keep some amount of space between the end of the lens and the cartridge to be able to hold the haptic properly. If you've not held the haptic properly, the haptic can break. That has happened in my hands also. So it's critical. You can see with minimal or no visco, there's no problem in loading the lens. I've purposefully kept this part of the video wherein you can see there's no need of visco. Even while loading your lens, you can do that with only the BSS. We come to the part of the actual surgery. Now we don't use the second instrument to be able to minimize the amount of aqueous humor that drains out while we are doing the side ports. This is a topical patient, so you can ask the patient to fixate on the light, and that provides enough resistance. Now this is where the hydroflow starts. Once that starts, you can see even while you're doing your entry and everything, the iris is not moving. That means it's absolutely stable. It's a rock stable AC. You do not require any viscoelastic to create that space. The fluid itself will create space, whatever is required. This is a toric ICL. You can also align the ICL under the fluid. You don't require any amount of visco. The rest of it is absolutely easy. I just want to show you that the pupil it's not fluctuating. The iris remains in place. That shows that the AC is deep. There are no surges, there's no fluctuation. Some amount of fluid will go out, but the newer phaco machines have the capacity to compensate for those, so the AC remains absolutely stable. You can carefully tuck it under the iris. Now once we've done this and we've aligned the toric marks, it's absolutely essential that you put air bubble before withdrawing your irrigation cannula to be able to maintain the AC. And this is a tip. We no longer use any kind of pilocarpine to keep the pupil down. Post-surgery, what we do is we change the BSS and we use a plain BSS without adrenaline to wash any BSS that was before, which had the adrenaline which maintained the pupil. The advantage of this is you will not have any kind of pupillary block even post-op because of the small pupil. The pupil size will go down before you discharge the patient, but it won't be as dramatic as in pilocarpine, so there's no chance of a pupillary block even post-op. So yeah, it can be done safely and consistently. I had no idea. I have supporters here, so I have added the line that it is time to remove the block from the eye of the patient and the mind of the surgeon. So thank you.
That was a beautiful presentation on that. So in our practice also, initially we were putting under visco, and we were having all those problems of early post-op rise of IOP. And the day we shifted to under BSS, that whole thing was gone.
Yes.
Not one case of raised IOP.
Yes.
So that was a miracle. Now, the only thing which is slightly different from my technique and your technique would be that I put viscoelastic in the cartridge.
Oh, okay. Yeah. Yeah.
Little, I don't fill it up, just a little for a little lubrication. And that amount is so minuscule that when it goes in, it is just a few flakes there.
Yeah.
And in any case,
they wash out anyway. Yeah, they wash out.
We really don't have to go after them.
Yes.
They just go off on their own.
Yes.
So they really don't create much of a problem. So, but your technique was also very smooth. So
Yes.
probably you can just do it without that also.
Yes, sir.
It's what suits your hand best. Otherwise, the results are very good. The time taken is very minimal because the main pressure is to take out the visco.
Yeah.
And somehow when you use a visco and the visco is between the crystalline lens and the ICL, taking it out requires a lot of irrigation.
Yeah.
And that irrigation causes what is called vacuolar changes in the cortex, subanterior capsule. So when I will be presenting my last case on worst case scenarios, I'll be showing you what damage you can do if you are irrigating under the ICL. So you have to totally avoid irrigating under the ICL. That is one very important carry-home message if you can take back from this session now. What a wonderful presentation.
Yes. Thank you.
Wonderful. But would like to know if the patient is not that cooperative, won't it cause sometimes some problem?
If the patient is?
Not so cooperative, like squeezing the eye or.
Sir, that can happen with visco or without visco. So,
visco will at least you have a safety of cushion having something
sir,
there. In the
that is exactly my point. We are using visco to create space. The fluid itself will also create space. We are not using dispersive viscoelastic anyhow. So we are using cohesive viscoelastic to create space basically, and the fluid itself will also create space. So whatever problems you have, apart from taking out the visco, remain the same. If it's not, you can give a block. We don't give a block. We use intracameral xylocaine in these cases. But yes, uncooperative patient in ICL is a problem whether you use visco or not use visco.
And Subhash, what we do is, in any case, these days we all have an anesthetist around.
Yeah.
And in cases which are very tense, or you think this is going to be uncooperative patient, the anesthetist knows from outside this patient is going to cause problems. So they have an intracat already into them, and if on the table they have a problem, they put in some midazolam, and the patient becomes steady and comfortable. That's it.
So any experience of doing the hydroimplantation in Indian factory?
Yeah, we do IPCL implantations under hydro. It has to be done with slight amount of caution. I don't know whether it is only in my hands, but sometimes the IPCL does tend to come out flipped. And then you have to use visco. There's no other way to unflip it. But we do use hydroimplantation is also for IPCL.
Because that is not so pliable as this ICL.
Yeah,
so
yeah.
that's the.
So it's not a question. You can. It's the same material as their hydrophobic lenses that we use. So if those can go under irrigation, this lens also goes under irrigation. The only thing is sometimes I've never had an ICL flip on me, fortunately, but I've had IPCL flip on me in the AC. It comes out the wrong way, and then there's no other way of unflipping it than to put viscoelastic and do all the maneuvers required.
So yeah, one question. If it flips within the eye, what do you do? Unflip it within the eye under visco, or take it out and put it in?
Sir, I have a video, not right now, but I have a video where we've put viscoelastic in the AC and unflipped it in the eye.
Yeah.
Yes.
I have also done that, sir.
Okay, but the recommended thing is you take it out, because when you flip it around, you are either hitting the endothelium, or in any case you are rubbing against the anterior capsule. There is no way out. You have to rub against it if you are flipping it in that area, and that is where the sensitive zone is, which is going to lead to an early cataract.
You can actually just pull it out.
Pull it out.
You just need to do a hand over hand technique and then reload it and put it. Otherwise, what he's saying is you can get both cataracts and endothelial decomposition.
Okay.
It's always more advisable to
More advisable to pull it out and then, okay.
Yeah. Another thing, okay, now you put visco, you take it out.
Yes.
Now you have to re-put it in.
Yes.
Will you put it under visco, you put it under hydro?
I've put it under hydro. This has happened a couple of times. I've put it under hydro. I clean the visco first, and then I've put it under hydro.
Yeah, perfect.
Praying that it flips, it comes out correctly.
the holes have aided that significantly because earlier you didn't have center.
Yes, center holes.
You have the center holes.
Yes.
So you can push both the irrigation as also do an aspiration. So that is the area which is maximally required for what he said, the vacuum which forms for the cataract. So you should actually spend some time and pull it out if you are doing it with the visco. The holes have aided in that,
Yes.
which were not there in the center.
Perfect. Thank you. It was a wonderful presentation.
Thank you, sir. Thank
the
you.
next speaker, would Vanasi?
Yourself.
Oh, you are ready?
It's yours, sir.
I'll come in the end, because
Okay.
I'm talking about the worst case scenarios. So we have Anusha Ajwani, and after that we would have Vanati.
switch करो ना.
So they are the good points of ICL and they are the bad points of ICL. Today I'll highlight the bad points of ICL. Yeah, please.
Good morning, everyone. I'm Dr. Anusha Ajwani, Vice Chairperson and Consultant at Ajwani Eye Hospital, Bhopal. And today I'll be speaking something about ICL in front of the big people. And I'll try to make it a little simple. So let's start with it. So phakic intraocular lenses, also known as implantable contact or Collamer lenses or implantable phakic contact lenses. These are lenses that are surgically inserted into the eye, where they provide excellent quality of vision with predictable and stable results. So it is a hydrophilic hybrid acrylic implant made of biocompatible collagen polymer known as Collamer, which does not cause reaction inside the eye and is positioned between the iris and natural lens. Coming to the advantages, firstly, it is far from the endothelium, causes lower induction of higher order aberrations, has superior contrast sensitivity. There is preservation of accommodation, which is a definite lead over RLE, provides excellent cosmesis and has retinal image magnification. Apart from that, it has a stable location, it is easily removable or exchangeable, there is no fixation into the tissues, and it does not alter the shape. Coming to the indications and prerequisites, the most common is patients who are not suitable for LASIK due to high powers or thin corneas, when the residual bed after LASIK is likely to be less than 250 microns, when the initial corneal thickness is less than 480 microns, and the patients should have an ACD more than 2.8 mm. They should have a stable refraction with no ocular pathology. Coming to contraindications, most common is corneal dystrophy or endothelial cell count less than 2000 cells per cubic millimeter and ACD less than 2.8 mm, and history of glaucoma, history of uveitis, and presence of anterior posterior synechiae, and evidence of developing nuclear sclerosis. So the most commonly used are posterior chamber ICL called EvoVision ICL, marketed by Star Surgical. The spherical ICL used for correction of moderate to high myopia from -3 diopters to -20 diopters. Toric ICL can correct up to -3 diopter to -23 diopter sphere and 1 to 6 diopter cylinder as well. The toric ICL has the same overall design as the spherical ICL with the addition of a toric optic. Coming to the lens design, it has a posterior curve to vault over the natural lens. There's presence of a central hole which allows for natural aqueous flow from posterior chamber to anterior chamber and eliminates the need of preoperative iridotomies and almost no cataract. The perioptic holes help in discarding the viscoelastic. Coming to the workup, firstly we need to do a dilated refraction, white to white measurement for ICL sizing, ACD measurement. The implant size is selected on the basis of horizontal white to white and ACD, and we need to add 0.5 mm to horizontal white to white measurement for IPCL overall length. Apart from that, the other parameters include a refractive stability, pregnancy, and we need to check for the retinal status, dry eye status, axial length, endothelial cell count, keratometry, and angle measurements. For the instruments we need for white to white, a digital caliper. In this, it has proven to be a simple but reliable method, and we need to make sure that the caliper is well calibrated and take the measurement with patient in supine position. Apart from that, there is optical biometer, pentacam, and however vernier caliper is no more used. So there are variations in white to white. If the digital caliper gives a reading of 11.7, pentacam or OpScan can give 11.9 and LensStar can give 12.3. We need to evaluate discrepancies between the measuring devices and between both the eyes and both the eyes should have about the same white to white. Coming to sizing and vault, an ideal sized IPCL will provide a vault that is central distance between the anterior surface of the crystalline lens and posterior surface of IPCL within a range of 250 to 750 microns. An ideal would be 500 microns, that is equal to 1 corneal thickness. High volt, that is 1000 microns, can result in angle crowding and angle closure, glaucoma or pigment dispersion. A lower volt can result in contact with the crystalline lens and resulting in cataract formation. So the size of ICL varies with the white to white measurements. Like if the white to white is 10.75 to 11.14, the size of the ICL would be 12.1 and so on. And the white to white measurement must be horizontal 0 to 180 degree. Newer studies state that in sizing the ICL, a formula that includes a direct measurement of sulcus diameter by UVM provides vault height predictability and hence safety for ICL implantation compared with the current standard of using a white-to-white based sizing formula. Coming to the loading of IPCL, it has already been covered by him very well. So the only thing, improper loading can result in upside down implantation. So we just need to be a little careful. So the lenses of different brands have different designs. IPCL here has a special patent hole on the upper left corner to ensure the proper direction of the lens while loading into the cartridge and unfolding inside the eye. We need to observe the IPCL for proper orientation in the cartridge, and anterior side of the lens is facing upwards. These are the steps. We have already been through that. Procedure under topical anesthesia, 1 or 2 side ports and 2.8 to 3.2 mm clear corneal incision, viscoelastic. In this technique, I have injected that. He does it in hydro. So viscoelastic is injected on top of the ICL to give more room. We do not inject the IPCL completely until you visualize the landmarks, as you still have control as IPCL remains in the cartridge. IPCL has a tendency to flip because it is made up of a collapsible material. So just be a little gentle and slow with it. And the ICL foot plates are tucked behind the iris. To control the potential cyclotorsion in supine position, the 0-180 horizontal axis can be marked preoperatively and on the slit lamp and reconfirmed on OT table. And complete removal of viscoelastic is a must to prevent post-op IOP spike and make sure the foot plates are behind the iris. Meiotic agent can be injected or you can leave the pupil dilated, followed by hydration of the incision. What if the IPCL opens upside down? So we need to wait and then put visco on top, to each their own method. We can take it out, like sir said, that is better actually, rather than doing this. But in this, I've put visco on top of the lens and manipulate in the periphery. Do the distal haptics first while the pupil is maximally dilated and avoid going across the central lens.
Can you please go fast or sum up, because we have 3 presentations, sir.
Yes, sir. Last is this. Coming to the complications, there can be decentration, crystalline lens touch, resulting in anterior capsular cataract, pupillary block, raised IOP. It may get stuck while injecting or might tear off, requiring manipulation, endothelial touch, pigment dispersion, and rarely endophthalmitis. Thank you.
Thank you so much.
Thank you, sir.
So just one question to you, before Vanti please take over. So Anusha, when you do white to white manually,
Yes, sir.
what do you take? Clear to clear, white to white, or mid to mid?
Mid to mid, sir.
Mid to mid.
Yes.
Any particular reason why do you take mid to mid?
No, just I've been doing like that, that's all. No, because of the pigmentation and everything, we can do like that.
Okay. So we were doing mid to mid before also, like you said.
Yes.
But now all these machines, they take a actual white to white.
Yes, sir.
So the measurements should be what the machines are also doing.
That's
So
correct.
that's why we shifted to white, and now we are
Okay.
getting more closer
All right.
reading,
Okay.
dependable.
Yes.
It's just a personal.
But then we do it on all the machines to
So all
keep
the
a close
machines are
check.
doing white to white actual?
No,
Or
not.
When they're
Yes.
crossing, the rays are
Yes.
crossing over,
Right.
they're differentiating between when the cornea starts from the sclera.
Right.
That's the true white to white.
Right.
So manually also we should be picking up that.
That
point.
only. Yes. Okay, sir. Thank you.
Thank you. Yeah.
IPCL has holes on all four foot plates. So the issue is there is a small protuberance on the leading haptic on the left hand side.
Yeah,
That has to be on the left hand side and the other has to be on the right hand side downwards.
correct.
So you can't go by the holes on the IPCL
Yeah, yeah.
as we go in Zeiss lenses or everywhere else.
And there are two holes which should be on the below the upper lid. I think that is two upper hole also. Total 9 holes are there. So that is also, that's why we call it a holy lens.
Yeah, Dr. Vanti. So it's a pleasure to invite Dr. Vanti over. And she would be talking about corneal biomechanics and refractive practice.
Yes, sir.
Something all refractive surgeons should be very well aware of. Dr. Vanti, please.
Thank you, Dr. Sanjay. And I think shifting gears slightly from the surgical mode to the biomechanical mode of what's the effect of refractive surgeries, laser refractive surgeries on the corneas, and no financial interests in the mention of any products during the course of my talk here. So we looked at how corneal biomechanics changes when we take up laser refractive surgery. So we did a study looking at the myopic femtoflap LASIK and related it to the amount of the percentage tissue altered here in routine LASIK patients here, and based on the type of on the amount of PTA, when the PTA was less than 27%, less than 33%, and less than 40%, which is all within the safe or described ranges of the PTA. And we looked at how this, of course, was done with the Ora machine way back. We didn't have the corpus was just coming in then. And we looked at how the corneal hysteresis and the corneal resistant factor changes when we are still doing it within the safe range of the PTA. And the correlations did reveal that when your ablations are on the higher side, when the PTA is on the higher side, that does produce a significant change with a mild negative correlation here. What we are looking at, or what now is evolving in our understanding in corneal biomechanics and imaging the corneal collagen, is now said to be more precise and more revealing with the Brillion microscopy here, which looks at the organization of the collagen fibrils here. I think I wouldn't go into the physics part of how Brillion microscopy, the scattering really works in this here, but just to make our understanding more simple, this is how you get high resolution macroimages of the collagen fibers using Brillion microscopy. And as you can make out here, the anterior fibers stop short at the periphery, and the posterior collagen fibrils do continue into the sclera, and that's how the normal structure of the collagen layering exists in the human cornea here. So what happens here is when we do alter this normal structure by laser ablations, either by cutting or by a lenticule removal, we are still causing a biomechanically weakening effect in the anterior part of the cornea here. And these fibers, which are stopping short at the periphery, now become mechanically inert, and the load which was borne by these fibers is transferred onto the posterior collagen fibrils here. So this is the biomechanical change which is happening, and I guess still we are yet to look at a machine which will be effectively be able to pick up this biomechanical change induced effects on the cornea following all types of laser refractive surgeries which we are performing here. What we currently have with us is the dynamic imaging of the cornea here, and this perhaps is the only machine which is now helping us or increase our understanding of what is the biomechanical effect of laser refractive surgery. So largely the earlier pre-screening modalities helped us to describe or differentiate a normal cornea from a biomechanically weak cornea, which is a keratoconic cornea. Most of us do pick it up because it's quite obvious. The difficulty arises when you will have to pick up the formae frustae or the subclinical keratoconus cases when you're taking these up for refractive surgery screening. And as we all know that more and more patients are now opting for refractive surgeries here. So the onus lies on the surgeon in being able to pick up those subtle abnormal corneas here and pre-treat them with the available newer modalities, which are probably you would want to prep them by a collagen cross-linking, or you would like have to do other contour related laser refractive surgeries before you embark on refractive correction for these patients here. I won't go on into all these research aspects, the various the waves which are described by the dynamic corneal imaging here, which largely I think is of particular importance when you're looking into research here. But Corvus does help in giving us a biomechanically corrected IOP here. It helps us to assess the collagen cross-linking and gives a better predicted outcome of our refractive procedure which we are adopting to. Helps in formifrosty and subclinical keratoconus reduction and applications in glaucoma management as well. There are multiple parameters here. There are about 14 to 16 parameters which one takes into analyze if you're looking at the research mode of application of this device here, and won't trouble you with a lot of those data, but something which in particular is the integrated radius, the ambrosio relational thickness, the stiffness parameters, and these are, and the applanation time. So these are particularly important ones which we need to look at and which we compare when we are looking at those corneas which are going to be susceptible to a post-LASIK ectasia if you're going to continue a surgery on these. This does give you what is known as the Corvus biomechanical index and the tomographic biomechanical index here. The tomography incorporated into the biomechanical assessment is the Corvus biomechanical index here, which helps you to pick up those subtle corneas which might be predisposed to post-LASIK ectasias here. So when we look at, we have the deformation amplitude, the applanation length, the corneal velocities, the arc lengths, the deformation ratios, and the inverse radius here. These are particular parameters which really help us to assess, and some of them increase and decrease depending upon the change, the biomechanical change induced by the laser refractive procedure adopted here. And this does give you a color-coded indication, and it helps you to understand how these are changing. Again, we do not have clear-cut values to say above this and below this it's going to be a clear-cut one of a weak cornea. But what we do have is the CBI, the BAT, and the TBI indices, which help us to understand if these are corneas which we have to red flag before we take up. Again, a word of caution, most of this data, this artificial intelligence was based on the Caucasian eyes. It's still not a data which was extrapolated to Asian Indian eyes here. So I do take it with a pinch of salt. And when I do have a suspicious pickup on these, I correlate it with the topography pattern, look at the stability of the indices over two consecutive reports done 3 to 6 months apart, explain these to the patients, and before we take them onto a refractive procedure. So that's how I do adopt these, not on a hard and fast rule, but on a custom basis, on a case-to-case basis, to see how these indices apply to the particular cornea which we are taking up here. There are multiple studies which have come out here, and one particular which does talk about with greater applications to detections of subclinical keratoconus. I think more work is in this particular area in recent times, and probably we'll see more literature on this to help enhance our understanding here. But what you would really look at, and when you compare it in terms of control eyes and with keratoconic eyes, some of the factors which are most important is the stiffness parameters and the deformation amplitudes. When they are moving away from the normal ranges is when you're probably going to be looking at these being abnormal, and warning you that these are predisposed cornea, and you'll probably want to consider an alternative procedure for refractive correction in these. Again, I think due to lack of time, we'll not go into much of the literature, but literature currently is quite controversial in telling. Some do tell that there is a biomechanical change with the order being more in femtoflaps, smile, and then surface ablations. Again, surface ablations also induce biomechanical changes, though to a lesser extent. But then I think there is a fantastic study which has come out from India as well, where they have evaluated the biomechanical change intraoperatively and postoperatively during the follow-up, and have not found a significant difference between a femtoflap and a smile lenticule. So literature now currently is not giving us a clear-cut evidence on whether it is which one is better, or whether to say one causes more than the other, and some do say that they are equally effective in causing a biomechanical change here. But we all do understand that when you're taking an ablation to higher levels or a lenticule removals to higher levels, it definitely does cause a biomechanical weakening in the corneas, which we are subjecting to laser refractive procedure here. So I think I will stop here in the interest of time, and thank you for your patient hearing here.
Thank you, Dr. Vanti. In the meantime, I can ask Dr. Kasturi to be ready. Dr. Vanti, just to save on the tissue, how would you compare the biomechanics of lenticule extraction versus flap?
So
Does
if
it
you
really make too much of a difference?
When you look at the scale of difference, the femtoflap is supposed to cause a greater biomechanical disruption as compared to a lenticule extraction. But there are studies which say that they are comparable when you're doing a lower myopia correction. Lower to moderate myopia corrections, it's almost equal in femtoflap versus smile here. And when you're doing higher myopic corrections is when a femtoflap is going to cause a larger amount of biomechanical disruption here. But again, there are studies to disprove, and one such is done from Bangalore itself by the Netralia group here, which does talk about, and that's an interesting study because they looked at the biomechanical change intraoperatively after doing the cut. They did a biomechanical and then completed the procedure and again looked at it postoperatively. And that particular study said as soon as the cut was done, there was a little difference, but not statistically significant. But after the procedure was completed postoperatively, there was not much of a biomechanical difference here. So there are contradicting evidence in literature, but I still follow that probably higher myopic ablations are definitely resulting. When your PTA is probably causing 35%, that 35 to 40 is always a gray zone, which I feel is going to subject the eye to a higher biomechanical change.
Thank you so much.
So out of 3 parameters like BAD-D, CBI, TBI, which one you think is the most sensitive and one should look upon?
See, the BAD is going to help you deduct a keratoconus. The frank keratoconus you can always look at, but when your BAD is falling, when it's red, you know you're not going to touch. But what you're worried is when it's in the orange and the yellow zone. That's when I go back and look at the TBI and the CBI. So the TBI is based on the topography indices only. The CBI incorporates the biomechanics into the topographic indices. So I do look at them en toto. And when it is on the orange or on the red zone, we don't touch. The orange zone and the yellow zone is when it always tells you. But it's always a pinch of salt. It's Caucasian data. It is not Indian data. Okay? So I always look at the topographic pattern to look for subtle signs of early keratoconus. And look for stability if for 3 months apart, or if you find the patient is more anxious, do it 6 months apart as well. Which means you've shown 2 consecutive readings to be stable along with the refractive and the topography here. Describe it and talk to the patient. Probably it takes a little more chair time with these patients where you have to talk a lot on counseling. And if you're on doubt, always offer an ICL.
Thank you, Dr. Van. Thank you so much. Dr. Kasturi, please.
Yeah, I'll be speaking on the outcomes of ICL. Due to the paucity of time, I'll be skipping first 1, 2, 10, 11 slides. I'll just start with this slide, which is basically my first patient. So this is a patient whom I have operated almost 15 years back, 2007. And this is the beauty of the ICL. This patient, he was a very introvert. He had minus 20 diopter of myopia, very much introvert. So that is when this is 15 years back when I have started. What I felt that it has really changed his quality of life. And now, like very recently, I met him after 15 years. Now he has started his own business and he's doing very good in his business career. So that is what I feel, that these patients with very high myopia, they have such an introvert lifestyle with so much of inhibition. This ICL really brings about a big change in the life and really affects not only the quality of vision, but definitely the quality of life. And though I'm following this patient till today, we have heard of so many complications of ICL. I have not seen anything like a glaucoma or a cataract in this patient. So when we initially started the ICL way back, that what we used to do, basically we used to check them after every 2 hours, because at that time we did not have the center flow IOL. So it was a very big worry for us, like whether there's a vault is okay or not, whether the IOP is okay or not. So these are the changes we used to see in the initial days, and we make it a point that the resident will go and see this patient after every 2 hours, measure the IOP. So those days have changed, because nowadays what we have the center flow IOLs, and you have the openings which leads to a very good flow of the aqueous. It is very well controlled, and this EVO or the EVO Plus lenses has really brought about the big changes. And I feel that the ICL itself is not a very challenging surgery, but what important is that since this is a phakic ICL which you put already in an eye which already has a lens, you should be very soft to the tissue. And also the most important today, we have the toric ICL, where the advantage of this toric ICL is also you can correct the astigmatism, align it, the ICL in the way that you have marked on the axis that needs to be placed. And the company people, they usually give you the, calculation how much clockwise or anti-clockwise you need to rotate. So this is again another of the patient which I want to show. But what I want to insist here, like especially for the juniors who are starting, it is always, this is a very customized lens. It is not that we have it in a store. We do not have it in a stock. So what we do, we basically load this IOL before opening the eye, because this is a very thin lens, 50 micron optic. So in case if there is a breakage of anything, it is always better that you load the lenses, keep it ready, and then you open the antechamber and you put the IOL. So, ICL. So these are some of the ICL that I'd like to say, and the complications, there are many, but what I have basically seen, yes, there can be elevated IOP. I have seen high and low vault. I have seen also cataract, especially some of the patient operated 12, 15 years back. But this is also one complication which I have seen, which was done by one of my students outside, and that is what he has referred. And this is the ICL which has been placed upside down that you can see here. And this is a slit lamp image that can also happen. So you should be very careful. And other complication which I have seen is a low vault, and if it persists for more than 5 years, I usually believe that it needs to be exchanged, because I feel that if the vault does not get corrected, that means the lens is little smaller. So you need to remove it and also place a bigger size lens in order to have a good vault. So we should not keep a very low vault, because the chance of cataract is there if you have a low vault, and the cataract, which is already a complication that we know. And this, it is easier like when you have a cataract, because even if you touch the lens, nothing happens. So what I feel that when you go for ICL exchange for a low or a high vault, it is little tricky, because you should not touch the lens, it will lead to other cataract. But if the cataract has already developed, so you can easily take out the ICL from the same incision and then go ahead with the cataract surgery. So this is what you can see, one of the patient who had developed cataract, who was operated, and they're very high myopia. So you can see a 3-piece IOL that has been placed in this patient. He had he had developed cataract, operated, and this is not, this is a routine ICL which was done, and that was not the center flow. But this is also one of the patients. You can see at initial days we used to do a iridectomy. We never had the center flow, so we used to do a iridectomy in order to prevent the glaucoma, and then you go ahead with the cataract surgery. So these are some of my cases that I like to show, because I have been given only 5 minutes. So we can correct the different high degrees of myopia, and it is less likely or even doesn't cause much of dry eyes. And now we have the EVO Plus, which has got a bigger size optics, and thus it gives an enhanced quality of vision. Thank you very much for your patient hearing.
So the last speaker is Dr. Sanjay Chaudhary himself. Just 5 minutes, sir.
Yeah, okay. So I'll just make it very, very brief. So now, in the end, we talk about worst case scenarios of ICL. So far, all of us have been talking about the good of an ICL or a phakic IOL technique, but it does not mean that everything is rosy, cherry, and good. There are always problems. So let's hear of some problems which we can take care of. So the first and the foremost, very important thing that you should know is there is something called anterior subcapsular vacuolar changes. Now what does this mean? Now look at this. This patient was we've seen on the first post-op day, and if a normal person would look at it, what will he say in the right image here? Visco deposit on the crystalline lens, right? Now, what if I tell you that there was no visco used in this case? Then what is it? So let's explore what it is. Here was another case. The same case. On the 30th day, the thing started resolving. See this little lamp image? The same thing is resolving. On the 30th day, visco would have gone off within a few days. This is taking time. And when we took images, this was anterior subcapsular. So we looked up the literature after we had some 3 cases as such, and it was said that these are vacuolar changes, and the result is because of direct irrigation in the narrow space between the ICL and the crystalline lens. This is what I was talking to you about in this session in the beginning. And as a result, there is a development of transient, the word is transient vacuolar changes in the crystalline lens. And then it is observed that there is spontaneous reversal. Indicates that the surgeon should not rush to surgical interventions, but rather opt to choose follow-up over several weeks. So first thing is, like I just talked about, that if the lens is upside down, the first temptation is just flip it inside, and it can be done very easily. It just takes a second to flip it across. But this is the problem that would happen in the long run. You could have anterior subcapsular vacuolar changes. Now, as long as they are reversible, it may take a month to reverse, 2 months to reverse, not a problem. But here's the situation. Look at this amount of anterior subcapsular vacuolar changes. I said, fine, it will reverse. So we started following it up. And this was at 3 months. The haze is getting denser in the center. This was at 6 months. It was clearing up from the periphery and accumulating in the center. This is the ASOCT image. You can see all this area, cataractus changes in this area. And this is all that accumulation of that vacuolar changes. Now a pacified lens fibers. This is the cataract. And we had to do a cataract surgery because it was in the center, the visibility was down. So this case, we felt we have burned our fingers. It's very awkward to tell a patient just after 6 months that you're going to do a cataract surgery. But well, we could learn something from this and be careful when we deal with the patients in the future. So inference, do not irrigate between the ICL and the crystalline lens. That is the carry home message. Come what may, just irrigate over the ICL. But there's so much of visco under the ICL. And you're always tempted, yaar, isko bhi nikal do, nahi to ye sara ka sara secondary rise of pressure karega, glaucoma karega, nikal do. And that temptation, you have to resist. Somehow, just please don't go under the ICL. If you can take this message home, it will help you in the future. Second thing which we encounter now and then is a high vault. We know 2 things about a high vault. That the vault decreases with time in ICL, and if it is a very high vault, it can cause its associated problems, the angle closure from the side and rise of secondary pressure. So here is one patient, size of ICL was 12.6, and look at the level of the vault. Both eyes. This is the right eye, vault 1400. This is the left eye, vault 1376. This was really high. Do we wait and watch for the vault to come down? No, we can't afford to. Anytime it will go into an angle closure. We have to do something fast. So it was decided we do an urgent explant. Replace it by 1 size lower. But now it takes time to get the same lens 1 size lower. So we monitored, and when it arrived, we decided that we are not going to take it out first and wait for 2 weeks and then do the other one. We said, let's monitor. If we land up into a raised IOP, we'll manage accordingly, but we'll do it in one setting. So this was a video of how we explanted this lens, and you see the difficulties we encountered in explanting this. So you had an ectropion of the uveal tissue because the iris was rubbing against the ICL. I'm trying to enter from the side. You can hardly go in. There's no space. See, entering from the other side. I'm almost rubbing on the uveal tissue, pushing the uveal tissue, trying to find a way in. But, well, I have found a way in. That was one. Trying to increase that space by visco. And then the main incision. Now the challenge was, how do I take it out? Because the standard teaching is, you prolapse the lens in the anterior chamber, put visco over and under and take it out. But here there was no scope of prolapsing that. So I had to hold it as it was in the posterior chamber. But once a grip was there, it came out easily. Then we replaced it with one size lower. Just one size lower, 0.5 millimeter. And see the difference in the vault. The vault has come down to right eye 710, left eye 212. It's come to a lower vault than normal now. See the dramatic change? So this dramatic change will happen in smaller eyes. In bigger eyes, you may not find such a dramatic change. Okay, one last one is a lens upside down. I'll just take a minute. So this patient was operated somewhere, lens was placed upside down. The surgeon did not realize that. So when it is upside down, the haptics are facing upwards and they're pushing the iris against the cornea. Total peripheral anterior synecdoche. And the lens is rubbing on the crystalline lens continuously. And the patient was given anti-glaucoma medication for 4 years by the doctor. And it just turned up. I saw that was my first case. And I said, okay, this is upside down, let's take it out. So I took out the lens, tried to break those peripheral synecdoche. And the question was, should I put in another lens or not? So this was a lens without the central hole. So we got another lens with the central hole. We placed it back. But what is noticeable is that even after 4 years and the glaucoma, there was no cataract. Unbelievable. They say, how can it be possible? 4 years you have an ICL rubbing on the crystalline lens, pressing on it. With glaucoma, even glaucoma 4 years you would have a cataract. And this patient fortunately was lucky, didn't have a cataract. Thank you so much.
Thank you, sir. So this brings to the end of this session. Thank you to all speakers, chairpersons.
Sorry for the
Sorry,
next
sir.
session,
Sorry
people
for
will
the delay.
taken in some of your time, sir. Thank you.
Okay. So, good morning, everybody, and I think it's time for the next session. I'll request the chairpersons.